This conference will now be recorded.
Okay. So this is the high-risk recurrent advanced prostate cancer group on the 12th of May. Rick Davis here with Jake Hannum and Len Sierra, and we're welcoming about 18 men to start off with. There may be a few more. I think there may be a couple of new people. We had one metastatic guy show up yesterday on Peter's group, and we asked him to come back today, but we don't see him yet. So we'll see if we see him. So I'm going to do a quick roll call, and then let me know if I missed anybody. I got a feeling I may do. Carl Foreman, Sylvester, Jake, Dennis C, Dennis M, Jerry Pelfrey, John A, John Hall, Larry Fish, Len, Leo Spessard, Les, Paul Frieda, Scott, and Peter Monaco. Anyone I didn't get?
Rick, you want a last name, or are you good with just first name?
Oh, I think I have most of the last names. Sometimes I call them out, and sometimes I don't.
Okay.
So,
I think you missed me, Robert.
oh yes, I did miss you. Hello, Robert. Thank you. And are you the gentleman that was in touch with Peter, and then I wrote to you subsequently?
I am.
Okay, and we know who you are. And I think you've been in Peter's group, but you've never been in our group. Is that right?
You're right.
Okay, excellent. Okay, so you qualify as a new guy for us, and well, hopefully we can help you out and give you some ideas as to where you might find some good docs. Okay. So, Robert, if you're comfortable, maybe you'll take 10 or 15 minutes with us, 20 minutes at the beginning now, and tell the group a little bit about your history, and then we can talk to you about how we can help you. Would that be okay by you?
Yeah, that's fine.
Okay.
Back in July, I came up with a urinary retention. Wound up in the ER a few times and was referred to a urologist. After going to the urologist a few times, I was referred to another urologist who was a surgeon. We had the top surgery performed. After the surgery, which was a success, 2 weeks later at my follow-up, I was advised that I had prostate cancer stage 4. They tested two sides of the two different pieces of the tissue. One was a 4, the other was a 5. So that made my Gleason score a 9. Following that, I went to see an oncologist who prescribed Lupron. No, the urologist prescribed Lupron, and the oncologist prescribed later. So now we move forward taking those two medications. And I just recently went and had a blood test taken, and the testosterone level was down at 4 in January, and as we speak today, it's 18. That was the story, kind of, summarized in its entirety.
Okay. So you live in the greater Philadelphia area, is that right?
Yeah, Allentown to be exact.
Allentown, okay. And how old are you?
64.
64. So you were 63 at diagnosis, or were you diagnosed last year as well?
No, I was diagnosed last year at 63.
Right.
Then I just had a birthday a couple months later.
Okay. Okay.
I am a black male,
Right.
and prostate cancer has been a hereditary issue.
Okay. And were you, how long had you wrestled with the urinary retention?
I think that went on to, well, I went through that from July until September the 13th when I had the surgery.
Okay.
And that was like 3 months.
Okay. And how are you doing now? Did it resolve the problem?
As far as me urinating, yeah, I have no problem in that area at all.
Good.
I mean, the cancer is there.
Yep.
I think my dilemma mostly is, one, why did the testosterone levels go up so high? And two, what can I do to bring it back down?
So there's a couple of answers there. Now, who right now do you consider to be your main doc?
Dr. Furon from St. Luke's in Bethlehem, PA,
Okay, and what sort of doctor is he?
oncology.
He's an oncologist.
Yeah.
Okay. Okay. Just making some notes here as we go along.
Now, I had originally started seeing the doctors in Pittsburgh, but I relocated back home, and I had all my records transferred, and I got copies of all my records in writing also. As a matter of fact, I gave St. Luke's Hospital all the records myself.
Okay.
And when I first went and seen the urologist here, and I told him what I was taking, he seemed to be impressed that I knew as much as I've known. And we agreed to maintain the same therapy. So this meeting with him tomorrow is my first follow-up.
Okay.
So in between my first meeting with him, my testosterone level went back up from 4 to 18.
Yeah.
So what he said was that maybe we need to look at a different type of therapy.
Right. So why don't I have a few thoughts, but why don't I open it up to the guys and see what sort of thoughts they have. I mean, Peter, you want to, since you and did you and Robert speak on the telephone, or did you just
both? We're talking. Right. Robert came to a meeting in October, and then I didn't hear from him, but he called me the other day, last week, and so we renewed our connection.
Okay.
Robert, what is your PSA history? Not the testosterone, but the PSA numbers since your surgery.
My PS originally, I think it was a 9 in the beginning,
Right.
and once I started taking the Lupron, he dropped down to a 4, and that was in January.
Right.
So I took another PSA about a week ago, maybe, if that long, and it has risen up to an 18.
Oh, so it's that's what I thought. It's the PSA that's up to 18, not the testosterone.
Yeah.
Those are different things.
Right.
Okay, that's a red flag for sure. Yeah, testosterone I wouldn't worry about, but that's probably still low. But it's the PSA that I was concerned about. That's why I followed up with you in the letter, and that's why we're suggesting that you might want to find a really good oncologist that specializes in prostate cancer because it sounds like that something's on the move still, and the question is what's the next step, and it might be beyond these local docs in Bethlehem or Allentown. So that's
Right.
So I was similar to you. I was had urinary retention. I think I wrote to you. I had surgery and that cured that, but I'm also Gleason 9. And I also have cancer that keeps coming back, and I've been managing it for 6 years. So this is not the end of the road or anything like this. You just need, like I do, to find really good doctors to track you and give you really good advice and shepherd you through the treatment process. This stuff can run away from you.
So let me just clarify, because to avoid any confusion. So what was your PSA when you were first diagnosed back in 2019?
If I remember, it was a 9.
When you were first diagnosed, before you had surgery?
Yeah.
Okay. And then after you had the surgery, what was your PSA?
After I had the surgery, I was immediately put on the Lupron 2 weeks later, and it went down to a 4.
Okay, so were you
That was
tested?
September.
So you really weren't tested after the surgery and before you took Lupron?
Right.
Right. Okay. It's usually they'll wait, but I think in your case, what happened is that they saw that you had, as I recall, you had some lymph node involvement.
Yes.
And so they immediately put you on. So we don't really have a good reading of your PSA after the surgery, but it was around 4. And now it's back up to 18. Have they done any measurements of your testosterone? Do we know if your testosterone is fallen?
I will not know that until maybe tomorrow, because the results of the blood work I haven't gotten yet, but I'm sure I'll be able to get them from the doctor tomorrow.
Do you know if they tested your testosterone in either February or March?
I don't think so.
I don't think so. So they should test it now just to make sure that you're responding. Because the first thing is we got to make sure that you're responding. Now, what about scans? What sort of scans have you had?
I've only had the original one prior to surgery, and my guess is that we're going to schedule one to see if there's any movement of the cancer itself.
Right. So, Len, what would you like to? What would your thinking be for Robert?
Well, I had a problem and I dropped off, and when I came back, I may have missed this, but I'll ask anyway. Rob, what is? Do you know if you're seeing a GU specialist for medical oncology? Peter says no. Okay.
No, he's not.
Yeah. So okay, that would be the first thing you should do, and maybe Rick, who knows that area, can help you identify a good GU medical oncologist. The second thing is, as far as we can tell here, you are already what is considered castrate resistant. So in other words, you had an early loss of sensitivity to the hormone therapy.
Right.
Yeah. Okay. So yeah, you definitely need to consider another form of therapy, most likely radiation therapy. When you say you had two, I think you said a couple of lymph nodes, pelvic lymph nodes, positive?
Yes. Yes.
So when they did the surgery, did they remove the lymph nodes or no?
No.
Yeah, so you may very well be looking at some what they call salvage radiation therapy, where they will radiate your, well, first probably they should do a scan and then see what areas need to be radiated, maybe the prostate bed, whatever's left, plus the pelvic girdle, we call the whole pelvic region. That was helpful to me. I had positive lymph nodes when I was first diagnosed, and the radiation uh, pretty much wiped it out. So hopefully it'll work for you as well.
Glenn,
I think
you might have missed it, but he's also on Erlita.
right. Yeah, that's why I said he's castrate resistant already. So I would suggest also you talk to your doctor about maybe dropping the Erlita and trying a different second line anti-androgen. There are several. Um, I don't want to load you up with too much information that may not be familiar to you right now, but there are similar drugs like Nubeca or Xtandi or Zytiga. So you have other options because your Erlita does not seem to be working for you. But these are just things you need to talk about with your new doctor once Rick or someone else on the group here who knows the GU medical oncologist in your area. Once you get started with that new doc, that's something you need to talk to them about.
Well, I think what we need to do first of all is introduce the concept of why Robert needs another doctor. My guess is that he's sitting there thinking to himself, well, what's wrong with this guy?
Yeah.
So, we're here saying, well, you need a different doctor. So the reason for that, and some other guys may want to jump in here and talk to you from their own experience. The reason for that is because prostate cancer is pretty complicated, and it's treated differently to most other cancers. Not all, but most other cancers. And a lot of the local medical oncologists don't necessarily stay current with what's going on in prostate cancer right now. And now, if you find a medical oncologist who specializes in prostate cancer, you have the comfort of knowing that they are most likely going to be completely up with the most current types of treatment. And it's not to say you got bad treatment or you're getting bad treatment right now, but it is to say that you might not be getting the best treatment. So what we would like to do is to suggest to you, if you're open to it, consulting with they're called a genito-urinary medical oncologist. Are you on the, Robert, are you with us on the telephone or are you online?
I'm on the phone.
You're on the phone. So we'll spell it for you. It's spelled GenitoUrinary, genito-urinary medical oncologist, ONCOLGIST. Okay? ONCOLO, oncologist. Okay,
Right.
now.
I got that.
The closest to you would most likely be in Philly.
Okay.
And maybe, we've looked around, scraped around before in Pittsburgh. We haven't really found anybody there that we know and like. We do know that there are good people in Philly. There are good people in Cleveland. Those would probably be the closest to you, but we would say Philadelphia.
Can I jump in for just a second?
Go ahead.
MSK has a branch in Basking Ridge, New Jersey, which might even be closer to him.
No, it's not. It's northern New Jersey. Right, Carl?
It looks
Basking
like
Ridge
right
is,
down the road from Allentown.
It shouldn't be that far for him to go there. And of course, you know, in Philly, the Abramson Cancer Center where Susan Dumchek is located.
right. So where would be closer from Allentown? To go to Philadelphia or to go to somewhere like northern, Basking Ridge is middle New Jersey, right? Where is it?
Yeah, I think Philadelphia is closer.
Right.
It's right on 78, so it's a direct shot from Allentown.
Peter, let's not get into the exact details of where. We'll give him some options, but I think we're going to find that Philly's closer than going up to Jersey. In Philadelphia, there are two main options for hospitals. One is Fox Chase, which is associated with Jefferson Medical School, etc. And we do know a good guy there. His name is Gainesman. I'll spell that for you. It's Geynisman, Gainesman. Okay. There's also
He's at Fox Chase?
He's at Fox Chase.
Okay.
We know people who have seen him. They like him. You know, I think he would be a good option, Gainesman. Secondly, Abramson at the University of Pennsylvania is the other cancer center. I don't have a name there, but here's what we can do for you. I want to put you in contact with a gentleman called Joe Gallo, who helps Peter and Ken Mason moderate a couple of our other groups. He doesn't have advanced prostate cancer, but he's very knowledgeable. He knows a physician's assistant at Fox Chase, who he says is very helpful and very knowledgeable and knows all the doctors. And when we spoke to him last night about you, he said he would like to talk with you. He lives in Bucks County, Joe Gallo. Okay?
Okay. Mm-hmm.
So what we'll do afterwards is we have your telephone number, we have your email. Either I or Peter will connect you to Joe Gallo with a telephone number, and Joe knows about you, and he knows about Gainesman, and he may have some other ideas for GU Medoncs in the greater Philadelphia area. Now, is there anybody on this call right now who has any other suggestions for medical oncologists in the greater Philadelphia area? Okay. Here's our concern, Robert. As Len said, it's unusual for your PSA to rise so quickly after surgery. I think if it were me, I would be looking to try and see where it's coming from.
Right.
So
That's my. Go ahead.
So you need to get set up for some specialized scans. And because your PSA is at 18, you may not need the most sensitive of the scans because there may be enough there to indicate. But probably if it was me, I would be asking for a scan called Axumin. That's AXUM as in Mary, as in Nancy, Axumin. And that is a scan that's readily available to you and should be covered by your insurance. Okay?
Okay.
You can talk to your doctor right now about Axumin. He should know about it. If he doesn't know about it, that's a red flag for you already.
Yeah.
In the meantime, work to see if you can get an appointment with Gainisman or a similar GU Med Onc in the greater Philadelphia area, and think about what you're going to do. Depending on what metastasis shows, you may be a candidate right now for chemotherapy if you would consider it. You may be a candidate to switch your meds. If we knew what your testosterone was, you may just be a candidate for switching your Lupron to a drug similar to Lupron. Maybe that could work better.
That's what I'm actually thinking. It's the problem. I'm thinking that the Lupron is no longer working.
Well, it's not that the Lupron isn't working, Robert. The Lupron we have to measure your testosterone. The Lupron could be working and keeping your testosterone low, but the cancer is still growing.
Okay.
Okay, if the Lupron was not working, then you would be, you would have a high level of testosterone, and that's what we want to look at. That's why we asked you about your testosterone. Okay. So is there anybody else on the call right now, in the meeting right now, who has any other advice or thoughts for Robert?
Yeah, Rob, this is Len. Are you aware of any local prostate cancer support groups that you could contact, and maybe someone could go with you to your next appointment with the GU oncologist?
I'm sure that I can probably find one or someone. I mean, I wouldn't go alone.
Okay, good. Yeah, of course, it's always best to go with someone who knows a lot about prostate cancer.
Right.
Peter has done some research whilst we're talking. He tells us that the distance from Allentown to the Monmouth Hills, is it Monmouth Hills or is it Bedminster?
Bedminster.
Bedminster. The distance to the Monmouth Hills Memorial Sloan Kettering is only an hour. Here's the issue I have with the satellite Memorial Sloan Kettering. It's been our experience, and Carl, you can talk to this, that it's hard to get the really good genito-urinary medical oncologists when you go to Bedminster, and then you get stuck with whoever the local person is, and then you haven't been able to switch back. Now, we've got another lady who just came on who told us she successfully has switched docs at Memorial Sloan Kettering. But as far as we know, and we've had a lot of experience, nobody's ever able to change their doc at Memorial Sloan Kettering. Who you get is who you get stuck with. And I don't want to send Robert over to Bedminster, and then he finds that he cannot get a good GU med onc over there, and he's stuck with somebody who is not who we would prefer. If we knew he was going to get Michael Morris or Dana Rathkov, you know, or somebody like that, that's fine, but he ain't going to get him there. And that's the concern I have.
I think I'm going to wind up with Fox Chase, and I'll most likely seek out Dr. Geisenman.
Gainisman.
Gainisman,
Guynisman. Okay.
Right. I think that's the route I'm going to go, because I've heard a lot about Fox Chase.
Okay.
It's just that when I came back here, I needed to set up with someone to have my medical records transferred from Pittsburgh to here.
Right.
So I went to St. Luke's. Now I really haven't done any work with this doctor other than the first time him and I met. And he just continued what we were doing. And when I go tomorrow, in reference to my most recent correspondence with him, is we're going to look into a different mode of therapy.
Okay.
So he actually is just beginning to do any work with me.
Okay. Well, all I can say is, you know, don't jump too quickly in with him, and tell him that you're going to get a second opinion as well.
Right.
You
Absolutely.
With Fox Chase and Dr. Gainisman, and then
Right.
come back to us, and you know, we'll shepherd you and help you make the right decisions. But I think that all of this is smart, and you know, I would encourage you to act relatively quickly. I mean, I don't want to scare you, but I think there's something going on, and the sooner you act, the better it is.
Absolutely.
Okay.
Absolutely.
And we'll connect you to Joe Gallo, and he can talk to you about Gainisman, because he's aware of him from the support groups. He goes to the support groups there, and they may be able to give you more of a choice than just Gainisman. But Gainisman, I think, is okay. And we used to have a guy who regularly attended. We haven't heard from him in a while, Tom Van Zandt, and he switched over to Gainisman, and he liked him.
Okay.
So I have to reach out to Van Zandt and see how he's doing. Okay, well, we need to move on because we've got at least one other new person. Anybody else have any final words before we move on?
Rick, maybe genetic. I need to be he knows he's got inherited in his family.
Yeah, you know, that it's a very good point, Dennis. It went through my mind and then I forgot it. But yes, you know, another thing, Dennis is right. Another thing, Robert, is it may be worth your while asking the doctor if you can do some what's called germline testing, GERMLINE, germline testing. Because that will tell you if you've inherited any mutations from your family.
Okay.
And the reason it's important is because it might open up more drugs for you. Like Carl Foreman, who's on this call, is on a treatment now because he has an inherited mutation and he's doing well on it. So it may create more options for you.
Right.
Okay.
Makes sense to me.
All right, we'll stay in touch with Peter or myself, and we'll be sure to write to you afterwards with the contact information for Joe Gallo.
I will.
Okay. And our next meeting is next week. It'll be next Monday night. Okay?
Okay. I'll be there.
It'll be at 8 o'clock, not at 6 o'clock, okay?
I'll be there.
Okay. Now, we have another new person with us who was on our call yesterday. Barbara Discant and Barry Miller. Is Barry with you today or not, Barbara?
Actually, he actually is not. He had to make a painful choice between getting his exercise, we live on top of a 300-foot elevation hill, and he goes up and down it every day.
God bless him.
And we live way out. And this is in spite of being resistant to docetaxel and Xtandi, resistant all the way. And he's just started cabazitaxel. He refuses to give up, which is great. However, he just came home from his blood test and said, I've got to go down the hill. Barbara, represent me. So here I am.
So if
We've
I
had quite a
remember,
journey.
your name is Barbara Discant and Barry Miller, right?
Yes, and again, Barry would be here, except he wants to do it before it dips below 30.
Okay, so we never we love people who exercise, and that is never a bad reason not to join a meeting in our group. So God bless him. So why don't you fill us in a little bit on Barry's situation, how old he is, a little bit about his history, where he's being treated, and what he's on right now.
Well, Barry got a surprise diagnosis. He's 73. We're hikers. He was taking a 20-mile kayak ride and felt a pain in his hip. He thought he'd injured himself, went to the orthopedic emergency. They x-rayed him and they said, the good news is you didn't injure your hip's fine. The bad news is, what's that mass over there? And that is how he found out he had stage 4 prostate cancer. It was like he had no symptoms. And it was like all over. It was like through his hips, up his spine. And again, we got advice, treat him right away. We actually went to several consults, including Sloan Kettering, and they suggested that, first of all, happily, they sent him up to a medical oncologist. We went, the first person we could see, he's going. And he ended up with a urologist who said, you need a medical oncologist. And by then I'd figured it out. And we got a consult there and a consult back home in Rochester. And I also took him over the place. We went to Johns Hopkins, we went to Cleveland. It just seems to me each of them has a different piece of the puzzle. There's just so many variables and so much just changes by the minute that it seems like everyone you talk to has something different. So we were lucky we had our daughter on our team too. She's a leukemia survivor, and she and I went to every meeting with him. She sort of jokes she trained me as an advocate. But at any rate, the basic consensus is treat him immediately. So we went, and Dr. Rathkoff thought he should mainly be treated in Rochester at home so he wouldn't have to drive 300 miles. At this point, we would have driven anything. I mean, you put out a book on CD, go. But at any rate, he got started.
I can't hear
Excuse
you.
me? I'm sorry, can you hear me now?
No,
Can you hear me?
Yeah, I can hear you fine. Yeah, go ahead.
Okay, I'll get closer. You'll see my long nose, but that's okay.
That's okay. Don't worry, you're doing fine.
Where did you lose me?
No, it was.
Where did you lose me?
I think it was somebody talking to someone else. So just keep going. So we know that he's going to get treated in Rochester, and that Dana Rathkoff is calling the shots. Is that right?
We're hoping she does. She wants it, but at first it looked like we had a surprise diagnosis. Barry had no symptoms. He was in a minor kayaking accident, went for an x-ray. It turned out he wasn't injured, but they found the mass in his hips, and that's how we found out at 73 he has prostate cancer. Just no symptoms, nothing. But at any rate, we went to Johns Hopkins, Cleveland, wherever, and we still maintain contacts. I think it's important. So he got Lupron. He got Casodex and Lupron. His PSA went down from 60 to 5. He had his testosterone. We thought that was great. Then he made a decision at that time between apalutamide, which was just approved, abiraterone, and docetaxel. The thought that docetaxel was finite and you do it and it's over. He took it, it worked for 1 week, and then his PSA skyrocketed. Just started doubling like real quick. So after 5 treatments, they took him off and started him on Xtandi. Xtandi worked real quick, and then he started skyrocketing it again. It went back up from like 9 to 35 in 4 weeks. So at that point, we pulled out all the shots, checked out trials, called all the doctors we knew, and everyone seemed to think he should start cabazitaxel, which is what they often do next. And he just started it. He's having no side effects. He did real well side effect wise. I know people get them. They gave him Neulasta as well, which is boosts the immune system because of the COVID, and also they just didn't know what would happen.
Right.
We had to decide he's lucked out, no bone pain. And now we're in the process of looking at the next step and frustrated because at this point, his doctor in Rochester was fine for the routine stuff. In other words, if everything had worked, but he doesn't seem to know about the trials. We called Dr. Tagawa at Cornell Weill. He has several trials that Barry may be eligible for if the cabazitaxel does not work. So we sent to Foundation One. We had a liquid biopsy, and yes, we did a germline as well. If nothing else, not only does the germline ease open things, it also can reassure or alert your family members and their children if they may need to be watched.
Yeah, no, we understand that.
So that's where we are. We're trying to figure out what to do.
Okay, so
I'm frustrated because Dr. Fong doesn't know as much as we hoped he would. So now we're talking to everyone, and we'll see what happens from here.
So
thanks.
Let me just get a time frame on this. So when was this accident that he had in the kayak that diagnosed him?
August 11th.
So it was.
It wasn't car. It was kayak. It was kayak.
Yeah, kayaking. Yeah, I got it. So it was.
Car.
Yeah. So he
I
got
feel on the spot. Sorry.
So it was August 2019 that he got diagnosed, and now here we are now in May. And what is his current PSA?
Well, his last PSA was 35 a week and a half ago.
Okay.
The same day as he started on cabazitaxel.
Okay, and have they ever done any sort of biopsy on him or not?
There was one done in August, and the doctors rightly wanted a new one because it's metastasized. It's not there's nothing in his visceral organs, but it's all over his hips.
Time out. The one they did in August.
It was done. Well, in August they did a bone biopsy, and they repeated it 2 months ago, but couldn't get anything out.
Okay.
So they redid it again last week.
Okay.
Last week this is.
Okay. Bear with me. Just stay with me for a second. So they've done 2 bone biopsies, one in August, and they did one last week. Was the one they did last week successful, and were you able to send a sample to FMI?
Yes.
Good. Okay, now.
FMI? What is FMI?
Foundation Medicine. Sorry. Foundation Medicine.
Yes. They sent it this morning.
Okay, now, just if there seems to be any holdup or issues around Foundation Medicine, let me know, because we can help you move things along there. Okay. Now, he's never had his prostate biopsy, so we don't have any idea of a Gleason grade. Is that correct?
No, he also got a prostate biopsy for that purpose. He was Gleason 9.
4+5 or 5+4?
Whichever was, I think it was 4+5.
4+5. Okay. So I'm going to give you a couple of ideas, and then we'll open it up to the guys here. My feeling, if it was me, is that I would want to have a quarterback genito-urinary medical oncologist. And I would pick the one that I like best. So, you've seen Dana Rathkopf. Who did you see at Hopkins?
We saw Mario Eisenberger. And Barry was not as comfortable with him.
Okay, so you've seen Eisenberger, you've seen Rathkopf.
The other one we saw was Dr. Gupta at Cleveland.
Where?
Cleveland, at Cleveland.
Cleveland
The,
Clinic.
the Rochester person is a genitourinary oncologist. They just don't seem as up to speed as the ones in New York or Cleveland. He actually is a genitourinary oncologist. He would have never done anything else.
So wait a minute. So yeah, Gupta is a Cleveland Clinic, you said?
Yes.
And well, my feeling is you find your best quarterback, and then you try to get them to work with somebody local. Now, we've got guys on this call who are doing that. So, for
That's
example,
what we're doing now with Dr. Rathkopf. Dr. Rathkopf's doing that with us, right?
Okay, so in other words,
we're doing that, right?
So you've selected Dr. Rathkopf as your main doctor.
I'm not sure she considers herself our main doctor. She still wants the home, because of our distance, the home to be where we are. However, as things change, it may change. If he's doesn't respond to this next medicine, this may change.
Okay, so here's the issue. The doctor has to view themselves as being the quarterback. And let me, Ken, can you see if you can you explain how you work with Paul Korn, MD Anderson, but you have your local people, and who does what, or anybody else who has that distant relationship? Ken, are you there? Peter, why don't you?
Okay, I'll go. Barbara, I'm a Gleason 9 as well. I've been fighting this for 6 years. I'm at the point of chemo. I don't have as extensive mets as your husband does, but I've got pretty aggressive disease. And I'm at the chemo stage. From the get-go, I live in Hawaii, on the island of Maui, so there's nothing in Hawaii in terms of good oncologists. So from the get-go, I found one in Los Angeles. And he's been with me for 6 years now, and he's running the whole show. I mean, he's everything to me. I have a personal relationship with him. He answers my emails the next morning or a few hours later. He's right on top of things. He treats me like a person and not a patient or a number. So we started chemo about 6 weeks ago, and I chose to do it here. All my other surgery and radiation, everything has been on the mainland. And I've flown to California for it, but I chose to do chemo here locally. So I have a local medical oncologist who runs the thing on the ground every 3 weeks, and I consult with him on the phone. But he takes his orders from my doctor in California, because I know as an advocate for other guys that this local guy is kind of slow on the uptake and not familiar with stuff. And because I have a genetic mutation, that I've leaned on him to try to get him to give other guys the kind of treatment I'm getting now with chemochemicals, and he wouldn't do it. But because I'm working with this guy in California and he's giving me orders, now I get the treatment I need, and this guy goes along with it. So I have to work as the intermediary. Doctors don't talk to each other usually. So you got to go back and forth with emails and consults and this and that. So I wrote to Rick. Rick might have a comment about this. You're not far from Roswell Park either. I don't know if you've ever considered that.
Yeah.
You know,
we were actually there, and much as we liked them in a way, some people we knew didn't have the best experience in that department.
Yeah.
So, and we didn't either. We didn't either. We totally expected they were the ones, and they weren't.
Yeah, I agree with you. And Peter, you know, I mean, that Professor Gilbert, rest his soul, never could, he didn't have a good GU med onc at Roswell Park.
Right.
And so, you know, we know that. We know that. I mean, we had to send Bill, finished up sending Bill to Dana-Farber. Have you seen anybody at Dana-Farber?
No, we have not yet, although our daughter's in Boston, so we might. One concern I have with this is, and this nags on me. If there's a clinical trial, let's say at Cornell Weill, and I'm seeing someone at MSK, will they tell me about it? Or do they each keep them to themselves, and is it up to me or Barry to find them? That's why I keep making contacts at different hospitals, because they don't seem to mention each other's trials, so I'd have to be in touch with a doctor at each of them just to keep up on the trials. And is this common? Am I imagining this?
No, it is
He
common.
laughs.
It is common, and it really depends on your relationship with your doc, and you've got to lean on the docs. I mean, we've just had this issue with Dr. Rathkoff, and we've really had to lean on her to look further afield. She assures us she did. I believe she did, but I don't know if she would have done if we wouldn't have lent on her so hard. Now,
I thank you, because that's just what happened to me.
Yeah. Now, Ken Anderson, are you with us or not? I think Ken is not at his computer. I wanted to ask him what his experience has been with Paul Korn, to the extent that he's gotten Paul to look further afield. You know, my feeling is that there are docs that look further afield. You've just got to find the right doc, and that's a question that you've got to put to them. You have to call them for it, because they have this conflict of interest with their own trials. And if you tell them, you know, we're wise to you, doc. Now, are you going to only look at our trials, or are you going to look across the board for us? And you say that to them up front. They know what they're dealing with. Because you know, Barbara, you're your best advocate.
Yeah, I have to be. What happened was I finally called Cornell Weill, and although we're not ready yet, 2 of their trials may at some point become a fit for Barry. But over at Sloan, they just said, we don't have any trials for him. And when I pressed it, they just said, we don't. And then meanwhile, I found the other ones, which may or may not. It depends on what comes out in the genetics study. But I didn't like that categorical no.
No, I mean, you know, I think, Len, I mean, what's your feeling with Dana? You've met with her on, you know, on Richard's behalf. I mean, do you feel that she's narrow, or do you feel that she would go the extra yard?
Well, it's always good to ask her if she has consulted with GU Medocs at Weill Cornell or New York Presbyterian. They do talk. I can guarantee you, all those docs, they talk to each other. They're very close physically. They all know each other. Whether or not they'll, you know, be actively consulting, let's say Dana, whether or not she's going to be actively consulting with Scott Tagawa or Charles Drake at New York Presbyterian, who knows? But if you specifically say or request that they do consult with those hospitals, those doctors, then of course they will do it.
I guess I got proactive, and I actually called Cornell Weill and talked to Scott Tagawa, and he was willing to talk to me. And that was when I realized there were trials that might, you know, we don't know yet, but that might be in the offing. And I sort of felt funny that no one had mentioned them to me, because they're right down the street from each other.
Barbara, another thing is, you know, right now with the COVID-19 situation, most clinical trials have been suspended indefinitely.
Yeah, I hear that. This was before the COVID happened. Yeah. I wouldn't talk.
One of the reasons why a lot of people, many people join this group regularly is because they hear of the trials, because we talk about the trials in this group. So this group becomes a good source of information for people. But I think that it's up to you. You know, I'm in many ways, I'm so, even though I hate to hear your frustration. I'm so glad you recognize the issue, because since you recognize the issue, you're able to keep these doctors much more honest than if you didn't recognize the issue. It's up to us to keep them honest. And I would say, yeah, Dana's good. I don't know enough about the fellow at Hopkins. The guy we like at Hopkins is Antanarakis. But I have heard of this other fellow. I think he's good. I know that there is one particular doc that I would avoid from other people's experience at Hopkins, but that's not who you're seeing. I do like Dana-Farber. I think they've got we can give you 2 or 3 names over at Dana-Farber. But I think that what you've got to do is decide who that person is going to be. You know, it's no good saying, well, I think our person's going to be Dana Rathkoff, but then because she doesn't send you over to Tagawa, you decide, well, that's not the right one. I mean, basically what you've got to do is ask the doctor to coordinate and stick with that doctor and have them lean on them to get you to Tagawa, not switch around. You've got to decide who that right person is to be your main doc. You do need a main doc. I feel very sure about that. You can't keep switching around between, you know, whoever's running the best trial. That's my view.
Could you have any names? Do you have any names at Dana-Farber, by the way, of people you like?
Yeah,
we do go to Boston.
A lot of people that we've sent a lot of people to Sweeney, and they do like him a lot. Chris Sweeney. We love Ellie Van Allen, but he's not taking. He has a very small clinical practice, but he's wonderful. If you could get in to see him. Eliezer Van Allen, VanAllen. We like, what was his name? Hold on, I'll give you one more name. The guy that Bill saw, who's also a researcher, but sort of more of an academic, but Bill liked him a lot. His name was, begins with an A. Hold on a minute.
Agarwal?
No, not Agarwal. Agarwal's at UCSF. Hold on a minute and I'll tell you. Chowdhury. Atal, I think it's Atal Chowdhury, Chaudhury. I think his first name is ATOL or ATHOL. I'm trying to think who else. We get. Do you watch any of the videos, Barbara, of these GU medoncs talking? You're muted.
Wait, oh, there it is. I've watched a few of them. In fact, that's one reason Barry originally chose Dr. Rathkoff was because of what she described.
Yeah.
Of her reason.
So,
but I'm looking more at to some of the technical ones as well, so I can be up to speed on what the research is.
Well, look for, and we can send you. We can definitely send you some links. Watch a couple of the ones with Sweeney. There are a couple on our website under resources, and see if you like Sweeney. He has a very nice manner about him. He's Australian.
Yeah.
We won't hold that against him, but he's an Aussie.
Well, I appreciate that, and of course Barry will be choosing. However, right now he's chosen to exercise, and as I said, he's supposed to have a good time, and I'm supposed to handle the rest. And but he weighs in. He's a good man.
You're doing great work for him, and I wanted to mention a couple of things to you. First of all, we don't have your email, I don't think, so you need to send it to us. You can either put it in the chat window and send it directly to me. You can give it to me, or you can send it to info@ancan.org. But be sure to send us your emails so that we can send you some of these things and we can get you on the regular list. But send it to
you.
info@ancan.org and then you'll get onto our list, okay? Look at our
What was
website.
the other one?
And info@ancan, Alpha Nancy, Charlie Alpha Nancy, ancan.org. Look at our website under prostate cancer resources, and you'll find some links to some videos with Chris Sweeney. He's talking in one to Alicia Morgans and Chuck Ryan. I'll see what else we've got for you. I want to mention to you that we've got a caregivers group. And we'll sign you up for that. It meets twice a month. And you might find that helpful. Okay?
I would like that. I signed up for the forum for her. I spoke to Terry on the phone for that she's forming a new one as well, but I haven't signed on to the caregivers group because of logistics. You know, I think I do have it down when to get on. I would love to. I'd love to hear what other people like this are doing.
And two of the ladies on there have great experience with metastatic prostate cancer. So
thank you.
I just think that I think they'll be helpful to you. I think you're probably a better researcher than they are, but they are wonderful and they really have a lot of great experience. And the other thing I wanted to mention for your daughter is we actually have a blood cancers group too, which is just, we debuted last month and our second meeting will be tomorrow night. So
at this point, she's years and years past.
Okay.
Past the last chemo and living her own life. She graduated chemo and went on to college. So I think she might not do that now, but she stay in touch with Teens Living with Cancer, which was our support group back then. But thanks. I think she works with them now.
Okay, so we need to move on because we've got 45 minutes left and we want to get around some of the guys here who have questions for today. But be sure to send me that, send me your email right away, and then we're happy to help you and guide you any way we can.
Thank you all for being here. Thank you.
Oh, look at Jake. Look at Jake. Check that out, man. With our logo behind him in this thing. Whoa, I love it, Jake.
Oh, look at him.
Whoa, Jake, that's fantastic. Just before we leave, Barbara, is there anybody else who would like to give any thoughts or advice to Barbara for Barry? No? Okay. All right, well, I'm going to run down the list and see who needs some time today, and then we'll go from there. Okay. Carl, do you need any time?
Yes.
Okay. Sylvester, do you need any time today?
Oh, thank you.
No? Okay. Jake, any time for you?
No, thank you. I do want to say Barry's very lucky to have Barbara on his team.
Yes.
For being his researcher. So
yes.
No, I don't have anything for myself. Thank you.
Okay. Yeah. I think we all agree with that, Barbara. You're doing a fantastic job for him, and I think he knows that too. And by the way, we record this. I should have told you, we record this. So when Barry gets back, he'll be able to listen to the recording. It'll probably be posted by tomorrow morning, and he'll be able to listen to the recording. He can hear what we said about you. Okay?
Thank you.
Dennis Correa, anything for you?
Just a 30-second update, Rick.
Okay. Dennis McGuire, anything for you?
No update. Thanks, Rick.
Okay. Jerry Pelfrey, anything for you?
No, thank you.
John, anything for you?
Yes, please.
Okay. John Hall, anything for you today?
Yes, a simple question.
Okay. Larry Fish, anything for you?
Nothing today. Thanks, Rick.
Okay. Len, anything you'd like to talk about?
Put me at the end, Rick, only if you have time.
Okay. Leo Spasad, anything for you?
Nothing, thank you.
Okay. Les Shelderup, anything for you?
Not tonight, thank you.
Okay. Paul Frieda.
Nothing for me tonight.
Okay. Scott, you had a question. I think we've given you, we'll talk about it. So Scott has a question we know. Peter Monaco, anything for you?
No, nothing tonight, Rick, thanks.
Okay. David, anything for you, David?
No, I'm good, thank you, Rick.
Okay. Ken Anderson, anything for you? I don't know what happened to Ken. He must have fallen off the face of the earth here. But I don't think he's with us. Did I miss anybody? Peter! Oh my gosh! Peter! Oh my gosh, Peter! So sorry, Peter.
Yes, I had a question. I had a very erudite question.
Okay.
And a quick update.
Anybody else? Okay. If I missed anybody, send me a note. Send me a rude note in the chat window. And Jake, what is the YouTube that you put in there?
Oh, you mentioned our YouTube channel to Barbara. That was the link is to our YouTube channel.
Oh, that's just to our YouTube channel. But yeah, okay, you'll find that on our website. Now, Peter, why don't you kick us off?
Okay, quick update. I'm halfway through my chemo. And I think I mentioned maybe the last time that I was starting to get reactions to the prednisone, and I asked both my docs, why am I taking prednisone? And they didn't really have a good answer, so I've weaned myself off of it, and I've been doing great without it. So I think it's like a standard go-to thing, but I feel much better without it. I don't have the edema and swelling in my legs, and anyway, so that's one thing. The other thing, I was listening to one of the tapes this morning with Alicia Morgan's talking to Dr. Sator from Tulane, who's a pretty big expert on genetic mutations. And most of you know that I've got both a germline Lynch syndrome, an MSH6 driver, and I have a somatic driver of BRCA2. And right now I'm doing docetaxel along with carboplatin, kind of trying to target the somatic mutation on the BRCA2. But I guess my question is, and this might be way beyond all of us, I don't know, is there a way to determine what is driving the cancer, whether it's the somatic mutation or whether it's the germline mutation? Because eventually, after chemo, I'm going to have to go with either olaparib or go with Penzil, whatever it's called. You know what I mean? Yeah.
So it's a great question, and I guess we all have a pang of sorrow because we think, where's Professor Bill when we need him, right? And so, it's a question I think Bill probably had the best handle on. Len, we anoint you in the Professor Bill chair.
Well, as it turns out, I recall asking the great professor this very question, and he said, we really don't know. We really cannot determine for sure what the driver mutation might be. I just a guess on my part is that a germline mutation would be probably more important as a driver than a somatic mutation, but I have no scientific evidence to back that up. The other thing is, I don't know if you recall, Peter, I had also the BRCA2 somatic mutation when I was first diagnosed. But then when I had a bone biopsy, that did not show up. I had 7 initial mutations back in 2014, and my 2019 biopsy had only 1. So I asked Dr. O about that, and he said, well, it could just be a matter of sampling. He said, when they take a biopsy, it's a very small amount of tissue. It could be if they, move the needle a few millimeters one way or the other, it might have picked up some tissue that did have the BRCA2 somatic mutation. So the thing is, keep in mind, a germline mutation means it's in every single cell in your body. A somatic mutation, it might be in some of the cancer cells, but certainly not all of them. As we know, prostate cancer is a multifocal, multiclonal disease. So some areas of the cancer may have a certain mutation, other areas may not. But certainly, not only every cancer cell, but every normal cell in your body has that MSH6 mutation.
How were you able to get a second somatic analysis? I thought you could only do one in a lifetime. How were you able to?
Oh, well, the first one was on the house. It was at MSK, and they enrolled me in their impact, something called Impact. It was just their own research program. So I didn't pay for that. It didn't count officially, I guess, with Medicare. Medicare didn't have no involvement. Yeah.
And I just want to mention to Barbara that there's another option for you in the city is Dr. O.H. At Mount Sinai. We like him a lot. He's Len's doctor. A couple of our other guys see him, and he could be also a very good option for you for a quarterback doctor. Peter, it's a great question. I think the person to ask that to, and maybe we can do this, is Ellie.
Okay.
And Ellie's great about getting back to me anyway. And we could I could send Ellie a note and copy you and ask him if he can give us any guidance on that.
Okay. Thank you.
Okay.
We did the other day with UCSF, but they would get into those things, but it was just too general.
Yeah, I threw your question into her to Dr. Munster, and she did answer it, and she says they don't see a big difference.
Right.
But yeah, I know who else you can ask. Ask Jim McCoy.
Yeah.
Copy me, send Jim McCoy a note and copy me. And let's see what Jim McCoy says. And if he doesn't know, he can ask Pamela Munster or Alan Ashworth, and they'll know.
Okay.
Right? Put in the note that if you don't know, could you bounce this off Alan Ashworth or Pamela Munster and see what we can get from them? Right?
Right. Well, my plan is I'm throwing everything at this. I'm just wondering about the order, and I'll talk to Turner about it too, and which way to go after chemo.
Okay. All right.
And one thing, guys, in case that came up in my meeting last night, is UCLA is doing PSMA scans, gallium-68 PSMA scans again. So the door is open, at least at UCLA.
Right.
It's cash, but it is open.
Okay. Carl, what's on your mind today?
You know, since we're running out of time, I'll defer to you whether we can table it, but just quickly put it out there. There's a drug called Femara, which is an estrogen type of a control for those of us who are dealing with male breast enlargements.
Yeah.
And I was wondering if anyone has used it and whether it's worth as an option.
Has anybody looked at Femara? It's come up recently. This is the second time it's come up in about a month. Does anybody remember the first time it came up? I'm trying to remember the conversation. So I think it is, it's a drug that blocks estrogen, if I remember correctly. It's an estrogen blocker, because what happens is that when you're taking your Lupron, when you're taking your Casodex, you're blocking, an androgen receptor blocker, you're blocking the testosterone, but you're not blocking the estrogen. And so the estrogen goes to work, and so a lot of men suffer gynecomastia. You know, old school, we always said, just go get a shot of radiation. One shot usually does it. But there's newer thinking on this. And, you know, now people are talking that Femara is a better option. I will tell you, I actually asked a cardiologist whether there was any danger from doing single shots of radiation. And they said, no, there was not. But that was the old school. And then there were some other drugs that were also recommended. Len, what's your thought on gynecomastia?
Yeah, I believe I recall reading a clinical trial comparing not Femara but tamoxifen with breast irradiation for gynecomastia, and tamoxifen performed better.
And Ken Anderson's
tamoxifen is the same class of drug as Femara. They're both estrogen receptor blockers. Yeah.
Right. So tamoxifen's another option. And Ken Anderson, wherever he might be at this point in time, we don't know, is on tamoxifen. So you might want to reach out to Ken Anderson and ask him how he's doing on the tamoxifen. He said he was thinking of stopping it. But that's certainly an opportunity to get some feedback. Anybody else have anything on gynecomastia? Anybody else having issues?
I try to just ignore it.
Me too. I wear my wife's training bra occasionally.
I had, let's see. Well, not so much an issue. I went to Mayo for a second opinion on radiation, and I met with Vargas on Friday. He said no to the radiation, too many Mets.
Okay, Scott, we'll get to you. Don't worry.
Oh, I'm sorry. I thought you were asking about any other worries.
I know. I'm asking about gynecomastia.
I got you.
Okay. So no other input on gynecomastia? Okay.
Well, hold on, Rick, I was just curious. Usually gynecomastia is not an issue unless you're taking a androgen receptor blocker alone, monotherapy, without Lupron or something like Lupron. So, is that your situation, Carl? Or are you not taking Lupron or?
No, I'm on Eligard. Yeah, it was
You are?
Lupron. They switched me to Eligard.
Huh.
But you're not,
Okay.
you're not on an androgen receptor blocker.
Yeah.
I mean, you see, the thing is that it does stop the Eligard or the LHRH does stop the production of estrogen as well, which is usually why it isn't an issue. Do you think it's an issue, or has one of the doctors told you it's an issue? And where are you getting this Femara from?
Just my own research. No, the doctors, I haven't discussed it with them. You know, if I can, I'm living with it. I could live with it. I don't want to add any more toxic type of potential treatments if I can avoid it. So.
Okay, well, I think what Len's saying, and it did occur to me as well, but I didn't want to challenge you on it, is that it may have nothing to do with the Lupron. So you may want to be talking to your PCP about it, because it shouldn't occur. It should only occur if you're on a monotherapy with an androgen blocker.
Okay.
Okay.
People on Casedex have problems occasionally.
Yeah, that's right.
That's the only one I've ever heard of.
Well,
as monotherapy.
As a monotherapy, exactly. That's an androgen blocker. Okay, Carl?
Yeah, thank you.
All right. Dennis Correa.
Yeah, just a quick 30-second update. I just finished my 90-day, got my new Lupron injection, all my blood work, PSA's holding steady, less than 0.1, no testosterone detectable, and exercising every day, and I've lost 3 pounds.
Good man. Oh, that's great. No, that's really great. And this is just from walking around your subdivision?
Yeah, we got walking paths that I can walk on, so I'll go for 30 minutes, and depending on how I feel, we'll go how quickly I walk.
Well, you know, one thing, I don't know if you're allowed, can you pull a cart? Are you allowed to pull a trolley on your golf courses?
Yeah. Yeah.
So, you know, maybe.
Well, I haven't played though.
I know you haven't played, but when you start playing again, maybe it's an idea. Pull a trolley around 9 and take the cart round 9.
Yeah, I've seen guys that do that. They'll walk the first 9 with a cart.
Yeah.
Then jump on their partner's cart or something. But right now we're not doing partners on a cart. It's just one man per golf cart.
Well, make it, you tie a tow rope behind the cart, and you get a pair of roller skates. That's what you do. Oh, you tie a tow rope and you sit on the trolley. There you go. What do you think?
I think I'll just keep doing what I'm doing here. And then I got one of these contraptions goes on the back of a door. And it's got the rubber pulleys and bands and stuff that you work out. You can get a pretty good workout with it. So one day I'll do the upper body, and the next day I'll do the lower body. So it's keep it going.
So I have to ask you, how long have you been on the abiraterone now? I mean, you're amazing. You're never detectable. You just go on and on and on. You're like the ever-ready bunny there.
Well, that Zytiga really did the trick for me after the chemo, and then I had the recurrence. Started good PSA going up again, and Dr. Singh looked at everything and looked at my stuff and said, "We're going to put you on this," and that did it for me. So that with the Lupron, of course,
How long? How long have you been on the abiraterone?
about 3.5 years.
Wow.
I know. This is the man. This is the man. You know, the only thing that I am at all concerned about, and I'm sort of loath to raise it, but I think it's something that you should be raising with Dr. Singh, is that when we see men get huge, really great success with these second-line anti-androgens, it leaves them sometimes, when it stops working, with disease that is untreatable.
You
And
talking neuroendocrine?
small cell neuroendocrine, yeah.
Yeah.
You know,
That's on the agenda for my next visit with Dr. Singh at the end of August.
right. You know, I don't know if we can find out ahead of time. I don't know whether it would make sense to take a holiday, but it happened with Rob. I mean, Rob got 4.5 years out of Zytiga, but then we couldn't find anything that worked after the Zytiga. And, you know, we've seen it happen with Foodie now, who got 4 or 5 years out of enzalutamide. And so, and they know this. I mean, this isn't a hypothesis I'm creating. They know it. And I think we owe it to the men that attend this call to tell them that they should be raising this with their quarterbacks, doctors, early. Yes, it's great, the success, but is there anything we know we should be doing? You know what? In other words, what we really want to do is to fool the cancer, because the cancer gets too comfortable and then it finds the workaround, and then when it's found the workaround, you're in trouble. So we need to keep the cancer on its toes, as it were. Len, do you have any thoughts on this, or anybody else?
I have the same concerns as you, Rick. And Dennis, would you be comfortable with intermittent hormone therapy? Like take a drug holiday for a while and then go back on Zytiga if your PSA rises?
You know, I don't know if I would or not, because I'm dealing well with the ADT issues. You know, at first it was really it was difficult with all the side effects of it, but it seems like either I've gotten used to them or they're less having less effect on me. I know long-term ADT is fraught with problems. You know, neuroendocrine, of course, being the worst one of it, but cognitive ability, it's another one that's come up. But I also, for the present time right now, with what Rick sent out about the ADT possibly giving you a milder COVID-19, if in fact that you do get it, but it seems like from some initial observational studies, I guess I call them, that the 80 people on prostate cancer with ADT are not getting COVID-19 as much as people that have prostate cancer and are not on ADT.
Yeah, it does appear to be the case. However, keep in mind, it's the reason is that ADT keeps your T levels very low. And so you have very low levels of that protein 10'2, which is like a key to let in the virus into your lung cells. But if you've been on Zytiga for 3.5 years, I would bet dollars to donuts that your testosterone levels would stay very low for quite a while, certainly, 6 months. So just I would talk to your doctor about that, see what he thinks. But meanwhile, like you say, you get a lifting of that cognitive fog. You get to build up your bone strength, your muscle strength. Although
It's more than just a,
I'm contradicting myself here because if your T level doesn't go up, that's not going to happen either.
the cognitive fog is, I mean, that's minor compared to the longer term use where they're thinking that it has leads you to dementia and Alzheimer's, early Alzheimer's and early dementia.
Yeah.
You know, I don't want to go.
Switching them up.
I don't want to go too far down that road because we just don't have the time right now. Peter, what was that?
There's so many second line ones now. What about just switching them up? Like I did Zytiga for a year, then I went off. Now I'm on the.
Yeah, but that's right. I think what we're saying is raise it. I mean, you know, Peter may have a good strategy, Len may have a good strategy, but I think what we're saying is if you've had this great success, it's worth raising with Dr. Singh that maybe you need to switch it up in some way or the other to keep the cancer off balance. And you don't have to do it tomorrow or in June if there's still COVID, but let's, you know, put it on the table. That's all we're saying.
Oh yeah, it is.
Okay.
Yeah, there's one problem with that. If he stops his Zytiga, then he's going to have to worry about weaning off of the prednisone. So
right,
that's an issue too.
It can be done. It can be done.
Right. Let's keep moving along here. John Antonucci, what's on your mind?
Let me just check the time. Okay, I got two questions. I talked to, in response to your advice, I talked to the medical oncologist who does focus on GU. At the Hartford Hospital team I'm working with, and he says, no, you don't need me quarterback. Just call me when the surgery and the radiation don't work anymore, and I'll do my job. And I asked our radiation guy, he said the same thing. So in response to that, I called up Dr. Petrolak, Daniel Petrolak at Yale. You guys recommended that. I've sent my records and I'm hoping to get an appointment. And my first question is, am I asking him just the whole case for a consult, or do you guys like him enough that I should ask him if he'll follow my from beginning?
So, I mean, we definitely hear very good things about him, and he's very solid, Petrolak. And Len will talk. I'll let Len comment on that momentarily.
Okay, so
go ahead.
Sorry, John.
Okay, so if I like him, and he's willing.
Yeah, you're cutting in and out, John, so it's a little difficult to hear you.
Oh, yeah?
Yeah. So the answer is you've got to like him. If you like and feel that he is a guy that you can work with, then yes, ask him if he will take over your care, and you know you're going to keep treating your disease. You know you're a post-op 4+5. You're probably going to need some radiation at some point pretty soon as you recover. You've got a positive lymph node, and you'd like him to oversee what you're doing.
Okay, thank you. As long as I want to make sure you guys like him too. My second question.
Hold on one second. Hold on one second. Len, do you have anything to say on Petrolak?
Other than he's very approachable, he listens, he'll give you the time you need. I only had one consult session with him, but I was impressed.
Okay. So second question is, now I'm about to get my 6 weeks post-op PSA, and assume that very soon I'll be going on Lupron and radiation. The question is, if it's 0, should I still pursue treatment?
Who wants to, how about you, Peter? Do you want to take that one? And I just want to remind you that John did a radical prostatectomy in April, and he had seminal vesicle invasion and a lymph node that was positive in the pelvic area and a post-pathology of 4+5. So,
And I don't think the PSA is going to be 0, but
right.
These guys are not aggressive that I'm working with, and I wondered what you guys thought.
Right.
Make sure you ask for an ultrasensitive PSA.
Yes, I think that is.
And you're very similar to me. I made it 11. Just, you probably won't get 0, but you might get something below 0.1. And I just watch it, and usually we can, just keep watching the, try to get PSAs. See if the doctor will give you an order. It's a simple, inexpensive blood test. Have them do them every couple of months or whatever, but don't wait 6 months. And watch to see if it goes up to 0.2 or something like that. And then you'll probably want to start taking action. As I said, I made it 11 months before I did my radiation. There are some people that are doing it proactively, getting on it because they know it's going to come back. But I had some of
that's my question.
Too. So, but I don't think you're going to have trouble if you wait till it's 0.2 or something like that. It's slow growing enough unless it's going bananas, and we'll know that fast enough.
The recent I think it was forget the name of the trial. I was going to say CARD, but that wasn't CARD. That was the cabazitaxel trial. There was
Radical RT.
Yeah. What was it called?
Radical RT.
Yeah, radical RT. I mean, radical RT seems to say, it doesn't hurt you to wait a little bit. But anybody else have any thoughts on when you intervene with radiation after surgery? Russ, you're muted.
Yeah, I was 1 year post RP, and my PSA from under 0.06 to 0.08, and 1 month later 0.09. And with the help of this group, I got in touch with Dana-Farber, Boston, and I'm now on ADT and radiation. Now 59, so I wanted to jump on it early, unlike I did the first time around. So, I made the choice to be proactive with Rick and everyone's help to, to get things going. And Dana-Farber agreed with me. I'm a 4+3 points, 0.66 on. What's the decipher? So I'm on the kind of low end of the high risk, I guess, but I wanted to try to nip it in the bud as soon as I could and get a head start on it. It was just a personal choice to do.
Thank you.
Anybody else have anything to input, because we need to move along? Anyone else who has had either adjuvant or radiation? Okay. All right. Let's keep moving here. How about John Hall? You had a couple of questions, John.
Yeah, I'm finishing up my SBRT this Friday, and I particularly want to know what kind of follow-up tests and how soon should I be getting after finishing SBRT?
Okay, follow-up tests, and just remind us, you were diagnosed metastatic, is that right? I can't remember. I have to pull up.
No, I was
Notes.
not.
You're not.
I had a high Gleason score of 10, but it was just, there was no, nothing
Right.
outside the prostate.
Okay. So tests to follow up after you've completed your SBRT. Anybody want to take that one? No, come on, guys. Do I have to pick on somebody?
I had trouble hearing him, Rick. What was the situation there?
He's finishing up SBRT. John is finishing up SBRT as a result of a high Gleason score. Wants to know what he should continue doing. John, did they radiate the prostate bed as well or not?
No, not, I don't believe so. I think it's just the inside.
So they just radiated your and you're on and you are on Lupron, right?
Yes. 6 weeks.
4+5, 12 out of 12 cores, everything negative, and they've just radiated the prostate bed. We don't think that he's gotten any radiation to the pelvic girdle. Obviously, you've got to be doing regular PSA tests. The PSA won't give you a decent reading for about 2 to 3 months because the prostate is so fried. The question really that would concern any of us would be, well, is there a disease outside the prostate, especially since they're not doing any pelvic girdle radiation, which I think if it were me, I would definitely have asked for. Having said that, you're on the Lupron, so even when 4 months from now we might get a reading, we're not going to see too much. I mean, this happens to a lot of us. This happened to me. It's one of the issues about Lupron, where you're on it for a couple of years. You don't really know where your PSA is at, unless, of course, you become castrate resistant, which hopefully you won't. So, yes, you keep doing the tests that you keep doing, your PSA, your testosterone, to make sure that the Lupron's working, and you hold your breath. Are you taking, have you done a bone density test, John?
Well, I've done scans for my bones, and it was negative. I mean, there was no signs of any metastasis.
Right, but have you done what's called a bone density test?
I believe so. I'll have to check on that, but I believe so, yes.
Okay. Is your bone density normal?
I believe so, but again, I'll have to look at.
Okay, so a bone density test is different to a bone scan. A bone density test tells you how strong your bones are. And if you're going to be on Lupron or an LHRH for any period of time, you should always get a bone density test up front. Reason being that if you are osteoporotic, then they can give you treatment for that. That was my own personal case. I found out I was osteoporotic. I had no idea.
I know I'm not osteoporotic because I did have a bone density test that indicated it wasn't that.
Excellent. Okay, so you don't have to worry about bone density. I never did a bone scan for the 2.5 years I was on Lupron. Anybody have any suggestions as to what follow-up tests John should be doing other than a PSA and a testosterone check? And your blood work, of course, your regular blood work.
Yeah, I agree with that, Rick. I wouldn't advise him to hold his breath and see what happens. I would say just go ahead and live your life and don't think about your PSA or anything else until your next blood work is due.
I think that's much better advice than I gave you. Stand corrected. That's the way to go. Actually, to be honest, that's the way I did go, except that I had side effects from the hormone therapy, so it was kind of hard, but I just tried to plow right through them. But I think that's exact. I think Len's exactly right.
Easier said than done.
Yeah, easier said than done. Russ is right. Anybody else have anything, or we'll keep moving because we're a little bit behind, not too much, but a little bit behind. Okay. David Muslin, you had a quick question.
Yes, sir. Had my second Lupron injection yesterday. This could sound crazy. My ass hurts me so much I can barely walk today. Is that common? It wasn't that bad on round 2 when I had it on my right buttocks. On my left buttocks, man, I'm walking around, I'm limping. I couldn't run this morning. I'm like in bad shape because my muscles.
My question was, did you actually get the shot in your ass? Sorry.
That's okay. All good. All good.
Well, I can say something about this.
Yes, go ahead, Larry Fish.
So, like other people, I'm in year 5 of Lupron.
Yeah.
Whenever I don't know the nurse, you really should question the nurse if she's experienced giving Lupron shots. That they really should make sure it's like kind of warmed up a little in case they keep it in the lab refrigerator, and that they dissolve the bubbles really well. And by the way, I had Lupron shot yesterday as well. It's a little sore, and good nurse will dissolve it really carefully. And it's important. If they don't, it can be really painful for 3-5 days. Really want to sit down on it. When I talk to the nurses, I get the feeling that they put a little extra care into rolling it between the needle between their hands and making sure it's really well dissolved. I found that it helped, and still is a little sore for a couple of days, but nothing like a bad. When I had it once a bad shot, it was terrible for a week. That's the only thing I want to say is discuss it with the nurse and tell her, you'll have some experience by the time you get your second and third shot. Tell her, when it was bad and how to avoid that.
Was it, David, was it the same nurses who gave you the first shot?
No, remember I did the shot. I'm still down in Florida, so I did the shot down here.
What I was going to say to you is that Larry's so right. It so much depends on who's giving you the shot. Some of them are terrific. Some of them are not so bad. Most of us who have been on Lupron and gotten the shot in our ass have had good ones, and we've had bad ones. Some of them hurt forever and a day, and some of them you don't even notice. So it's not unusual. There isn't much solution to say. So if you're down there and you got a hot tub, go sit in the hot tub and massage the area. I used to try and, sometimes do some stuff with just try to massage it and move it around a little bit. But I don't have a better idea for you. Jake there gets it in his arm, but we don't know anybody else who does that, so that's kind of unusual.
I have a thought.
Yes.
Keep track of the bore size of the needle too. You may have gotten an 18 gauge needle the second time and a 21 the first time, something. If you keep track of it, then that's another variable you can watch.
Okay.
I've
Thank
had
you.
I've had 2 shots so far. Both of I've had in my shoulders, and I think the next one I'm going to get is going to be in my hip. So I'm just kind of rotating where I'm getting them. But I mean, they hurt for 3, maybe 4 days, but nothing that's not bearable. But the time I saw my Lupron shot, I thought it was for a horse.
One thing I was taught by a nurse was that you got to make sure you keep the weight off your leg. So whatever side you're getting the shot on, make sure you take the weight and the pressure off that leg.
Yeah, it's actually swollen where I got the shot.
Mm-hmm.
Yeah.
All right,
One
Jim.
thing I can promise is this too will pass.
Yes, sir. Thank you, Rick. Thanks, everybody.
Well, I know it doesn't help you right now, but try getting into the hot tub, massaging it and what have you. But I guarantee when we talk to you on Monday, you'll be fine.
Thank
And
you, Rick.
ice pack will help too.
Oh yeah, thank you. Okay, Scott, you wanted some help on getting financial support for your Zytiga, is that right? You're muted right now, Scott.
Yes, I did find that Janssen, they won't mess with you. You have Medicare and a supplement. They don't do anything. Anyway.
That's not been our experience. You're telling me that if you have Medicare with a supplemental policy, you're not eligible with Janssen?
Well, on the Janssen website, that's what they said. Maybe
Have you called the Janssen people?
Yes, I did.
And what did they say? You're not eligible?
Well, no, because if you have private insurance or commercial insurance, they will consider you, but not if you have Medicare. I can go in and check it out again.
No, I know that well, okay, first of all, before I say anything like that, who has gotten help here with copays? Who on the call has gotten help with copays? Peter.
I have.
Dennis McGuire. Okay, let's go. Let's just go around really quickly, everybody, and just tell me if you've got Medicare and supplemental insurance. Start with Jake.
Okay. I did not get help with Zytiga because I was on the generic, and of course, Janssen is not going to pay for the generic. But when I was on enzalutamide, also being on Medicare, they gave me $75 copay each month.
And you had a supplemental policy, right?
Yes.
Okay, Dennis McGuire.
Yeah, I'm on Xtandi with private insurance through Aetna, and I have a $0 copay.
Okay, but are you on Medicare or not?
Not.
You're not. You're eligible for it, by the way. You could apply. It would take some time, but we'll talk about that another time. Jerry Pelfrey.
I through Mayo in Phoenix, I got on a program through Mayo where, and I'm Medicare with a supplemental, and I've got zero copay.
And you're on Zytiga, right?
Yes.
Okay.
Well, yeah, Zytiga or
hold
Aberrant.
on, Scott. Let's just finish and then we'll come back to you. Peter.
Yeah, I'm on Medicare, but my secondary is not through Medicare. It's different. It's like Blue Cross. And they picked it up. They were to give me a $90 copay. And I talked to Janssen and they brought it down to $10 a month.
Right. And Len, have you had any experience with getting copay subsidies?
When I was on Zytiga, I think I did get some kind of subsidy. I don't know how I got it. At Mount Sinai arranged it, and I don't even know what they just asked me for number of people in my household and annual income, and they said, okay, you qualify. And I had a very low copay. I can't remember exactly what it was. Something like Peter said, maybe $10.
So
maybe it was something called Patient Assistance Fund, something like that.
That's another one.
Yes, that's what it is.
Yeah.
That's another one. Does anybody know if they got their copay directly from Janssen? Anybody who was on Zytiga, or if it was through another organization? Okay. Don't know. Scott, back to you. Tell us what you want. How you respond to that?
Well, yeah, it's the abiraterone that I'm on. Not Zytiga, just the generic. And so I'm looking for where there's assistance. Mayo said no, they don't do anything. I'd have to apply to foundations or something. And so I'm just looking. That's all I can do.
Okay, so
Rick, and on Mayo, go to their specialty pharmacy and talk to the people at the specialty pharmacy for Mayo, because that's how I got it.
I see.
Okay, do you know what a specialty pharmacy is, Scott?
That's what yes, I think I do. I mean, I've gotten from Ironwood, their specialty pharmacy, the abiraterone.
So let me just clarify a couple of things. When you said to me originally Zytiga, I didn't realize you were talking about the generic. So Janssen will not help you with the generic.
No.
Okay, that's clear. The specialty pharmacy should be able to help you. And I would definitely talk to Ironwood. And, you know, as it's another reason to possibly switch your care to Mayo and, you know, talk to Dr. Moore or Dr. Vargas. And when you speak to them, see if they can put you in touch with the specialty pharmacy to help you.
Okay, thank you.
Are those good enough? Now, what happened when you went to see Dr. Vargas on Friday?
I thought I thought I could do radiation. I was really hoping, but I had a list of questions for him. He walked in the door and his first thing, he didn't even look at the questions. He says, no, we can't do radiation. So I took a tape recorder in and I just tape recorded what he said, which was basically repeating over and over, no, we can't, radiation isn't an option.
Why was radiation not an option?
I think, again, from what I could decipher, there are too many Mets.
Okay, which is really what we were asking you to drill down on, correct?
Yes.
And I think that with 5 Mets, it's probably a considered decision. Have you talked to Dr. Moore?
No, I've had to, at Mayo, you have to put in it's a complicated process, but no, I have an appointment for next week to actually see her face to face.
Okay, so that's fine. So you'll see her face to face. and see what her program is. And when you
Yeah.
see her face to face, be sure to talk to her about the specialty pharmacy and getting some support. I mean, where is your thinking? Are you thinking that you're going to switch your care to Mayo at this point?
I really don't know right now. I found some things about Mayo that I'm really not very happy with, but I don't know right now.
Okay, what are you not happy with at Mayo?
It's very difficult to get an appointment.
What about our other men? We got two other men at Mayo here, Dennis and Jerry. Do you have any suggestions or help that you can offer to Scott?
Which Mayo is he going to?
Ask him.
Scottsdale.
Scottsdale? Well, I don't have a problem. I've got my profile. I've got my portal, and I just go on the portal. Although I found during COVID-19, the best thing to do is call directly to the scheduling. And at least at Mayo there in Phoenix and Scottsdale, the scheduling is in the hematology and medical oncology section, and it's a different phone number than just the straight phone number. But the scheduling people are really good. I haven't had a problem. Dennis?
Yeah, sometimes it's difficult. I do use the portal to schedule my appointments. Like I was scheduled to have my annual CT scans and stuff done back in April, and then they were suggesting, I was getting emails from Mayo to put off anything that was not a scheduled treatment type of visit, such as what mine was. I wasn't going for treatments. So I called them to reschedule it. It was a little back and forth kind of thing. You don't get it the first time. Sometimes you have to call back a second time. But I'm always able to, it always goes through. I always get essentially what I want, what I'm looking for.
I think the bottom line here, Scott, is that you have to learn the system. You have to have some patience, but you have to also go where you're going to get the best treatment. And my concern at Ironwood is, they'd be radiating you when you need more systemic treatment than that. And I think that you have to make the decision. Are you going to go where you get the best treatment, or are you going to go where you feel more comfortable on a day-to-day basis?
What do you mean by this? Is because I did have radiation for 8 weeks, but I'm not sure what you mean by the systemic versus the radiation.
Well, when we first talked to you, the way that your docs at Ironwood wanted to address this was to radiate the spots, correct? They wanted to radiate the lesions.
No. They radiated the prostate bed back in October, November, but then when they found through an MRI more mets, then they just said, no, we can't radiate. And then I got on the Zytiga, and that's why I went to Mayo to get a second opinion about radiation, and they said no to the radiation.
Okay, so I think the issue here is that with 5 Mets, and why we said you should see Cassandra Moore, that the the Zytiga may not be the best option for you. But chemotherapy may be more appropriate because you have higher volume.
Well, I know time's out, but I could go through a whole scenario that's completely different from what the other two gentlemen said. So I will see her, but it's very hard to get. You have to put an order in, and then and they have to call you, and it's not good the way they have it set up. But
Okay, well, I mean, both these gentlemen have been, I mean, Jerry started there with a PSA of 3,000 a year and a half ago. And Dennis has been there for a couple of years. So you have to do what's most comfortable. I think the one thing I would say to you right now is that if it were me, I would be looking at early chemotherapy rather than Zytiga. That's what I would be doing.
that's like the doctor said. Vargas said, "You're doing just fine. The Zytiga is the way to go, and we wouldn't do radiation." So, I'm not disputing what you're saying. I'm more like, these guys don't. You get a.
Well, the reason, as we've said to you, you need a quarterback. This is why you need a GU medical oncologist. And you're gonna get an appointment with that doc, and they may say 5 Mets, it's not high enough volume, stick with the program, and you'll see how you do. It's just, if it were me, from what I've seen over the last several years, I think I would jump right in with the chemo if I could, and then see how that follows up. But that's me. But everybody's different. Everybody's different. So you see how you do. Guys, I have to cut it off because we've got another meeting starting in this room in about 10 minutes. And Len, my apologies to you. If you want to talk, I'm sure both these guys, Jerry and Dennis, would you be willing to speak to Scott about Mayo?
Sure.
Yeah,
Okay.
Yeah, just a real quick one. Scott, I started off my original diagnosis. I had 5 Mets, and with Dr. Singh, when he was in Tucson, came highly recommended from everywhere. And it took me a while to get my appointment because you just don't call a person top of the thing and expect you're going to get right in. But fortunately, I had another oncologist that knew him well, and I asked her to put in a word for me after she told me he was highly recommended. She did. I got in within a few weeks, and I started with, because I'm very similar to you, and he said you really need systemic type treatment such as the chemo, so I did the docetaxel.
Now that's
and then he woke up to Mayo after, and I was upset because I was getting treated at Banner, and then he said, he told me, he said, if you have a problem, you're uncomfortable there, call me, and I'll get you in up there. So that's my story in brief.
real quick, Rick.
Time, Jerry.
Well, all I'm saying is I've got more Mets than Scott does, and Singh didn't start me out on chemo. He started me out with a month of Firmagon and then right into Lupron and Zytiga.
Okay, so we've got different things. I will connect you guys. Okay.
Okay. Thank you, Rick.
Thanks a lot. Good night, everybody.
Thank you, guys.
Thank you, guys. Have a good evening. We'll see you next week.
Good night, everybody.
Thanks, everybody. Thanks for everything. You guys are awesome.